how do I define critical limb ischemia? So critical limb ischemia is typically defined as Rutherford's 4 through 6. That's patients who have rest pain or a failing to heal ulcer. The first step is seeing them clinically. When these people come into the clinic and they actually have a wound on their foot, the first thing is noticing the location of the wound and using the angiosome concept to predict which vessel we're going to need to open up in the lab. The second thing is to obviously check pulses. Always check a dorsalis pedis, posterior tibial pulse, popliteal pulse, and femoral pulse, also to give you some indication of whether this is going to be multi-level or just a single vessel disease, such as runoff disease. The second piece in terms of the evaluation is non-invasive studies. Typically we use ABIs and duplexes and toe brachial indices to evaluate whether there is, again, multi-level disease, and if these are falsely elevated, so it gives you an indication of pathology such as calcium. And then the third thing is angiographically, determining where the locations are, and then providing treatment to improve blood flow to the wound to help it heal. The answer is absolutely yes. Remember that critical limb ischemia is a vascular problem. Let me give you an example. If we took 10 people, lined them up against the wall who had critical limb ischemia, approximately 67%, so about 7 out of 10 of those people would have had a blockage in one of their heart vessels either now or in the past. Out of those same 10 people, about 30%, 3 out of 10 people would have a significant blockage in one of their carotid vessels. We have very good evidence, outcome data, for cardiovascular and cerebrovascular disease. So in terms of the medical regimen that we would use, of course, aspirin, an antiplatelet, Plavix, another antiplatelet, statins to help prevent the inflammatory process, and also to help in terms of outcomes, not only from a peripheral standpoint, but from a cardiovascular and cerebrovascular standpoint. And then the other medicines that have proven benefit in other vascular beds, such as beta blockers and ACE inhibitors. It's a great question. So again, taking into account this clinical syndrome. So for instance, if they've got an ulcer on the great toe, my goal would be to improve perfusion pressure to that great toe through inline flow through the anterior tibial artery, because from an angiosome concept, that would be the artery that would be affected. However, if you cannot improve inflow, direct inflow to that great toe, then you would look for alternative methods to heal. As we know, the perineal gives off an anterior communicating branch, so my next line would be to try to improve flow to the perineal, to improve flow to the anterior communicating branch. If that was not possible, then I would also try to improve flow to the posterior tibial, because it wraps the pedal loop, backfilling the anterior tibial artery. We know that the number of vessels below that are open directly affects inflow. And what I mean by that is a lot of these people, especially that are older age, diabetics, and renal insufficient patients, have multi-level disease. So if they have a procedure, endovascular procedure on their inflow, that inflow depends on the outflow. Galeno and Davies has shown very eloquently that if you have 1 or less tibial vessels, your fem-pop patency is about 30%. However, if you have 2 or greater tibial vessels, that fem-pop patency increases to about 70%. So when is enough enough? So we know that our inflow begets our outflow begets our inflow. So you would want to open as many tibial vessels to keep the patency of your inflow if it's multi-level disease. Number 1. Number 2 is you want to try to increase your perfusion pressure to the wound such that we heal the wound. So the question is, do I see the incidence of CLI and amputation increasing or decreasing in the next 10 years? I strongly believe, and we've already seen a trend, that this will continue to trend downward, that we would have a decrease in amputation rates in terms of critical limb ischemia. Now, why is that? I think it's 3 pieces in terms of endovascular intervention. The first one is tools. our tools are evolving from an endovascular realm. A carpenter is only as good as his tools. So as the tools evolve, it helps improve our success rates in opening these vessels. Number 2 is skill level. The skill level is continuing to evolve, and there's a higher standard in terms of not only opening above the knee, but opening below the knee vessels. And then thirdly, patience. So to be successful, you have to have the patience because these are typically long procedures. So people are understanding the importance of healing wounds in terms of people who have critical ischemia, because there's an obvious not only morbidity benefit, but mortality benefit. So again, I believe that amputation rates and critical limb ischemia healing will improve over the next 10 years for the 3 issues I said. Number 1, skill level. Number 2, evolving devices. And number 3, people understanding that it deserves patience in terms of these long procedures to open these vessels.